Om Swastiastu. Hello everyone, my name is Huliana Lim and I am the representative of Student Group Discussion B8 Ugrasena Medical School. In this occasion, we will going to present our student project of this blog, which is Endocrine System, Metabolism and Disorder, with the given topic, Tumor with Ectopic Production of Hormone. And this is our group members, and the presentation will be continued by my peers. Thank you.
Hello everyone, my name is Bagus with my number is 2025184. So let's start with the background. Tumor is a condition which cell undergoes uncontrolled growth and is followed by activations of oncogenesis. Tumor are also usually characterized by deactivations of tumor suppressor genes and the absence of apoptosis. In some cases, the tumor secretes hormones in the body. However, tumor that hormone that produce outside of the original gland is conditions called endocrine paraneoplastic syndromes or tumor that produce bioactive substance from the plastic cells from the endocrine. In this paper, we will discuss mainly about that conditions or named tumor with ectopic hormone productions. Tumor with ectopic hormone production, or commonly known as endocrine paraneoplastic syndromes, are conditions when certain secretory components such as hormones, cytokines, and etc. are not associated with the expected organ or tissues of origin that can lead clinical manifestation to the patients. So the research of the question, as you can see, is what is the condition of the tumor with ectopic production hormone, what is the epidemiology, how is the classification, what are the risk factors of it, what is the pathogenesis of it, and what are the clinical manifestation of it, how to diagnose the tumor, how is the treatment or management available for the patient with tumor, with prognosis, what is prognosis can occur in this patient, and the last one is what complication that can occur in the patient with tumor with ectopic production hormones. So the objective on this paper is to understand from the list of the problem, so we can understand the topic that we will discuss next. The benefit. So the benefit, as you can see, is the first one is the complete knowledge of tumor with ectopic production of hormone. The second one is to learn more about the tumor with ectopic production hormone. The third one is know how to treat ectopic production hormone, and also the last one is increasing knowledge in the community who have a better understanding of tumor with ectopic production of hormone and the appropriate therapy for it.
Hello everybody, my name is Putu of the Karama Yoga and my student identification number is 200251104. So in this opportunity, I want to explain the definition of tumor with ectopic production of hormone. Ectopic or inappropriate hormone production is the synthesis of hormones by tumors from tissue that do not normally produce the hormone. Ectopic hormone production in a tumor could therefore result from an alteration in the tumor cell type's DNA binding protein environment, which is activating the enhancer of the hormone gene, or from a change in the enhancer or silencer region adjacent to the hormone structural gene. So that's all the definition of tumor with ectopic production of hormone. The presentation will be continued with my friends. Thank you.
My name is Gede Raka Abdi Samudra, number 023. Now I will explain you about the epidemiology. Based on the SEER or Surveillance Epidemiology and Results database as shown in Figure 1, we have seen 25,531 patients diagnosed with GI carcinoid from year 2000 to 2019. Gastrointestinal carcinoid predominant patients are white, 72.7%, with a male to female ratio around 1, and an average age of 60 years. The most commonly impacted GI sites are small intestine, 45%, rectum, 20%, appendix, 17%, large intestine, 11%, and abdomen, 7%. This disease is characterized as a metastatic cancer, or 43.2%, and about a half of it, or 23.8%, spreads to other parts of the body, distant metastatic. In most cases, 75.5% GI carcinoids can grow for years, and most of them, for 83.9%, are at the first stage of cancer. That's all from me. Thank you.
Hello, my name is Azza with registered student ID number 094. I will explain about the classification of ectopic hormone. There are several types of ectopic hormone associated with paraneoplastic syndrome. The first one is ectopic ACTH or adenocorticotropic hormone. The most common cause of ectopic ACTH production is the expression of pro-opiomelanocortin or POMC from the tumor. In patients with cancer, This happened in patients with small cell lung cancer. The second cause of excess ACTH production is the tumor production of corticotropin-releasing hormone. Ectopic production of this peptide can cause pituitary corticope hyperplasia leading to Cushing syndrome. Second one is ectopic PTHRP or parathyroid hormone-related protein. PTHRP can cause hypercalcemia by binding to PTH receptor and activating the expression of an osteoblast-specific cell surface protein, Angelyne. The interaction between cell and receptor result in increased bone resorption, increased osteoclast differentiation, and hypercalcemia. The third one is ectopic ADH or antidiuretic hormone. This event is often referred to syndrome as syndrome of inappropriate secretion of antidiuretic hormone or SIADH. SIADH is a condition in which the release of ADH from the pituitary gland or other source occurs without suppression. This condition is characterized by impaired water excretion that can lead to hyponatremia with hypervolemia or euvolemia. Fourth one is ectopic IGF-2. Increase in IGF-2 is often associated with the occurrence of hypoglycemic syndrome. Increased circulating IGF-2 activates insulin receptor and will cause hypoglycemia. Last one is ectopic GHRH or growth hormone releasing hormone. Of the chronic disease caused by ectopic GHRH is acromegaly. This can happen because the excess production of GHRH by tumor will lead to increased stimulation of somatoprops and increased secretion of growth hormone. That's all from me. Next.
Thank you for the opportunity. My name is Krishna Putra Pramanda with student number 128. So now I would like to continue this presentation about the risk factor of endocrine paraneoplastic syndrome. Paraneoplastic syndrome are accompanied by underlying malignancy, but the exact mechanism remains unclear. The syndrome commonly manifests in lung cancer, breast cancer, hematological malignancies, medullary thyroid cancer, gynecological malignancies, and prostate cancer. Endocrine paraneoplastic syndrome results from the production of bioactive substance from neoplastic cells of endocrine or neuroendocrine origin. Typically, these are located in the lungs, the gastrointestinal tract, pancreas, thyroid gland, adrenal medulla, skin, prostate, or breast. In primary care patients, all levels of hyponatremia are associated with increased all-cause mortality, whereas hyponatremia per se is linked to an increased risk of being diagnosed with any malignancy, particularly pulmonary and head and neck malignancy. I think that's all from me. This presentation will be continued by my friend. Thank you.
Hello everyone, my name is Gloria Grace with last three digit number 162 and I'm going to explain about the pathogenesis. So when inappropriate genes are expressed and unscheduled gene products appear in an atypical cell, the tissue or organ could experience a neoplastic process. The presence of neoplasm makes human immune system modified. This process could lead to paraneoplastic endocrine syndromes. It happened because there is immune cross-reactivity between malignant and normal tissue. Moreover, the tumor secretes hormone, peptides, and cytokine lead to this disorder. The body will release antibodies to bind and eliminate tumor cell. However, the cross-reactivity can happen and eventually it destroys the normal tissue and stimulate paraneoplastic syndrome. The symptoms might be endocrine, cardiovascular, renal, cutaneous, neuromuscular, or musculoskeletal, hematologic, or gastrointestinal. When the symptoms develop, serum tests will show large quantities of ectopically related hormone. So that's all from me. The next slide will be presented by my friend. Thank you.
Hello everyone, my name is Angelyne Mulia with the last three digit numbers 051. So next I will explain about the clinical manifestation. The clinical manifestations of tumors with ectopic hormone production may be similar to neoplastic lesions found at the expected site of origin, and it has various manifestations that affect multiple organ systems in the body. First is tumor with ectopic adrenocorticotropic hormone production. The common clinical manifestations are centripetal fat distribution, electrolyte disturbances such as moon face and buffalo hump, plethora of face and neck, metabolic abnormalities such as glucose intolerance or diabetes, peripheral edema and increased bruising, poor wound healing, abdominal striae, hypertension, hypokalemia, proximal muscle weakness, psychiatric disorders, menstrual disorders, and hirsutism on women, and osteoporosis. Next is tumor with ectopic antidiuretic hormone production. The clinical manifestations are not specific and depend on how the degree and rapidity of hyponatremia occurs. The mild symptoms are nausea, vomiting, fatigue, headache, memory difficulties or confusion, and gait disorders, while the severe symptoms are altered mental status, seizures, respiratory collapse, coma, and death. Next is tumor with ectopic parathyroid hormone-related protein productions. The clinical manifestations are nausea, confusion, fatigue, loss of appetite, bone pain, polyuria and polydipsia, and constipation. Next is tumor with ectopic insulin-like growth factor 2 production. The symptoms are neuroglycopenia and hepatoadrenal mediated, such as confusion, drowsiness, impaired judgment, blurred vision, tremors, diaphoresis, palpitations, and coma. And last is tumor with ectopic growth hormone-releasing hormone productions. The symptoms are headache, flaring, arthralgia, skin thickening and weakness, and a tendency towards hypertension and glucose intolerance. That's all from me. Thank you.
Hello everyone, my name is Huliana Lim. My student ID number is 2002511080. Now I'll going to talk about the diagnosis of tumor with ectopic hormone production that is made by clinical, biochemical, and imaging assessment. Clinical evidence of neoplastic without native endocrine disorder can lead to paraneoplastic endocrine syndrome. This followed by clinical symptoms and biochemical reduction along with treatment. Biochemical tests such as blood transcript analysis and NET tests can be used to identify relevant tumor mRNA for specified hormone synthesis. Imaging diagnostic can also used to determine primary tumors or metastases that are associated with endocrine dysfunction. For the example of the tests are CT scan that have high sensitivity and specificity for lung cancer, and then MRI or magnetic resonance imaging that can be used for diagnostic of breast tumor and colorectal cancer, and then elevation of universal serum marker chromogranin A in conjugation with typical imaging findings also can be used to diagnose concomitant neuroendocrine tumors or NETs. And then we have occultized scintigraphy that is essential imaging method that can help to locate the tumors in an eye patient or NET patient based on somatostatin receptor expression. Alright, I think that's it for the diagnosis. Thank you. Next.
Hello, my name is Huliana Saraswati with last 3 digits of student ID number 142. Now I will explain about the treatment of tumor with ectopic productions of hormone. So the first one is tumor with ectopic adrenocorticotropic hormone productions. So the tumor surgery is the main option. In addition, other treatments that can be offered are steroidogenesis inhibitors, which are the main treatment for controlling hypercortisolemia. The drugs that are often used are ketoconazole and metrapone, which are proven to be effective and safe to use. The mifepristone is effective in treating small retrospective ectopic adrenocorticotropic hormone syndrome. However, in cases where total tumor resections cannot be achieved, other modalities such as chemotherapy and radiotherapy will be used. If hypercortisolism cannot be controlled, bilateral adrenalectomy will be performed to save the patient's life. The second one is tumor with ectopic parathyroid hormone-related protein productions. So the treatment for this tumor is by the using extracellular fluid infusion, calcitonin, and chemotherapy. In cases of metastatic renal cell carcinoma, prednisolone is used as a treatment for hypercalcemia of malignancy. In several cases reports, it was found that bisphosphonates were used for the treatment of HCM due to the secretion of PTHrP and calcitriol. The third one is the tumor with ectopic antidiuretic hormone productions. So there is the main treatment that can be done to help treat SIADH by treating the main cause or underlying disease. If the main treatment is not sufficient, additional treatment can be added in the form of fluid restrictions, sodium administration via oral preparations, or in more severe cases, hypertonic 3% continuous infusion or bolus saline. The fourth one is tumor with ectopic insulin-like growth factor 2 production. So the treatment for IGF-2 producing tumors is surgical resections, which has the potential to also treat hypoglycemia. In some patients with advanced disease, treatment with radiation and or chemotherapy has been shown to reduce hypoglycemia, although at a lower level if after surgery, radiation and or chemotherapy. If hypoglycemia still persists, it can be continued with medical therapy in the form of glucocorticoid and recombinant growth hormone. The last one is tumor with ectopic growth hormone releasing hormone productions. The mainstay of treatment for ectopic acromegaly is surgery and resections of the involved tumor. If the patient's condition is contraindicated or in metastatic cases, somatostatin analogs are an alternative option to achieve biochemical disease remission by normalizing GH and IGF-1 levels. That's all from me. The presentation will be continued by my friend. Thank you.
Good morning, Dr. Fresh. My name is Felix. It's last series of student ID 099. I will continue presentation regarding prognosis. So there are three types of things that needs to be mentioned regarding the prognosis of the tumor producing ectopic hormone, which are well, first is the what type of the primary tumor, second is staging of the tumor, the third is what type of the ectopic hormone which are produced. Hypercalcemia caused by parathyroid hormone related peptide, ectopic hormone, are usually occurs around 10% of the malignancy tumor, which has poor prognosis in 30 days mortality rate, which are approximately 50%. Ectopic adrenocorticoid hormone syndrome has a prognosis depends on the severity of the hypercorticolemia and the location of the tumor. Patients with a better symptoms and better control of their cortisol have a relative long rate of survival. Patients with ovarian tumor with the ectopic GCSF producing hormone have a poor prognosis due to its effects on the tumor proliferation and promoting metastasis, which accelerate the disease progression and have a worse outcome. Thank you. Next.
Good morning, doctor. I'm Annisa Nuraini with the last 3 digits of NIM of 110. I would like to continue the presentation on complications. So complications of tumors with ectopic production of hormones depend on the type of the ectopic hormones being produced. The first one, tumor with ectopic adrenocorticotropic hormone production. Complications are mostly correlated with direct and or indirect effects of excess glucocorticoids. It could increase the incidence of cardiovascular risk factors and other complications. The next one, tumor with ectopic parathyroid hormone-related protein production. Overexpression of this hormone is associated with higher incidence of brain metastasis, hypercalcemia, and decreased survival rate in breast cancer patients. The next one is tumor with ectopic ADH hormone production. So hyponatremia has been associated as a complication, also could cause a high risk of brain metastasis, advanced disease stage, and lower survival rates. The next one is tumor with ectopic IGF-2 production, really associated with hypoglycemia. And the last one is tumor with ectopic growth hormone releasing hormone production. A recent study actually presented a rare case of acromegaly caused by an ectopic GHRH secreting tumor. Other complications that may occur includes carcinoid heart disease, diarrhea, and abdominal pain.
Hello everyone, my name is Natasya Pusparani with a 3-digit number of 227, and here I will present our paper's conclusion. Next. Okay, so tumor with ectopic hormone production or endocrine paraneoplastic syndrome is a condition in which the body's secretory components such as hormones, cytokines, and others are produced by tumors from organs or tissue of origin that do not normally associate itself in the production of that certain hormone, which can result in clinical manifestations. There are several types of ectopic hormones associated with paraneoplastic syndrome, including ectopic ACTH, ectopic PTHRP, ectopic ADH, ectopic IGF-2, and ectopic GHRH. This syndrome can also be accompanied by underlying malignancy due to being locations of bioactive substances from neoplastic cells. So what can provoke tumors with ectopic production of hormone? So it can be due to modified immune system as a response to neoplasm, and also can be by immune cross-reactivity between malignant and normal tissue. This condition can have various effects throughout multiple organ systems and may not always correlate with malignancy. Diagnosis for this syndrome can be made by clinical, biochemical, and imaging assessments such as CT scan, MRI, chromogranin A seromarker, and octreotide scintigraphy. As for the treatments, it will depend on the patient's case and adjusted according to the type. There are several possible complications related with cardiovascular risk factors, metastasis, hyponatremia, and hypoglycemia. For the prognosis, it would depend on the histology of the primary tumor, staging, and its type. Some may have poor prognosis due to being malignant or have high ability to metastasize.
Thank you. That is the end of our presentation. And lastly, this is our references that we used in this Zoom project. Okay, thank you. I think that's it for our presentation today. Thank you so much for your attention, and sorry if we have many mistakes. Om Santi Santi Om. Goodbye.